Okay, so we can go ahead and get started, and I'll just start off with some introductions for our speaker today. So we're thrilled to have Dr. Perice here with us, who will be talking about some of his ongoing work. So Dr. Perice is an assistant professor with Brown Emergency Medicine, and he is specialized in the use of emergency ultrasound. So his area of interest is in creating digital innovations that tackle clinical and educational problems kind of within the field of medicine. And his innovation approach is to find solutions for inefficiencies by using data and knowledge that are already available. He's currently working on a reference tool for regional anesthesia that would enable emergency medicine physicians to more routinely perform these procedures, which are really performed in the emergency department and are during active clinical care. And he's also working on creating a digital ultrasound curriculum for medical students to learn ultrasound interpretation in a more efficient manner. So we're thrilled to have him here today for our seminar series and to learn more about the work that he's doing. So Dr. Perice, I'll turn it over to you. And thank you so much again for being here with us.
Yeah, thank you, Kristen, for having me and everyone at the Center for Digital Health. I'm going to share my screen here. And I will say, if you guys, because we're going to save questions for the end, if you have any questions, feel free to throw it in the chat and I'll try to read them at the end. I did work overnight, and so one of my fears is if I don't entirely elucidate a concept that I might have done better otherwise, then I'll still be able to answer it if you specifically point that out. My name's Leland. I'm one of the, as was said in the introduction, one of the attendings in the Department of Emergency Medicine. I've built a digital niche in developing mainly mobile applications, but I've gotten involved with the use of tech for trying to innovate through problems that we see a lot at the bedside and in medical education. And my goal today is to try to convey a more pragmatic approach to creating such digital solutions. I find at the CDH, for example, there's been a lot of amazing talks and how to establish the empiric evidence behind such interventions. But I feel like what helped me most, especially as a trainee, is a kind of pragmatic development kind of understanding and design principles in order to be able to actually get started creating such things myself. I'm going to get started. I do have one conflict of interest. I'm currently a paid consultant for Pieces Technology. They're using AI to improve the use of EMR and its efficiency. I won't be talking about any work I've done with AI today, and all the work or the examples I talk about of the mobile apps that I developed in this lecture were done before I started this work. So real quick, the basic talk layout is I'm gonna really first define what I mean by designing and innovations and intuitive and kind of bring it together. And then I'm gonna show specific examples of how I apply these principles. And so getting started, in terms of talking about design, if you were to Google design or ask, I guess, ChatGPT, what comes to mind, one of the first things that people talk about are objects that, so to speak, evoke a positive visceral reaction. And the easiest example of this might be handbags, it might be objects that are well designed. And that's, I think, what occupied the public consciousness of what design's purpose is. And I think one of the silver linings of COVID is that it kind of brought to attention to kind of society as a whole, the kind of power that design can have, and not only creating a certain kind of reaction, but actually guiding people's behavior towards more positive outcome. And you know, the great example of this is shown in this picture here. We have Domino Park in Brooklyn in New York City. And during the pandemic, obviously it was kind of a scary experience to go outside and go near people. And nobody would have been able to enjoy the park if not for these very well thought out design intervention where circles were placed at the correct distance so that everybody can comfortably enjoy the park and know that they were at the right distance. And I think COVID kind of really brought this kind of power of these terms that we use a lot nowadays, design thinking and social design, social intervention. And I want you to try to keep that idea in mind of guiding people's behavior through good design as I go through this lecture. And I also want to say, obviously, this is not a new concept. This is a book I took from design thinking, or this is a page I took from a design thinking book, and this is an example of different stove layouts that have been tried not only throughout the past few decades, but even to this day. And if you ever stop and think about it, the layout affects how we interact with the object. And if you kind of think through it for not too long of a time, you can figure out an intuitive way to map it. But unfortunately, that's not done. And this has resulted in probably a few extra burned hands, at least for burners that warm up slowly, or trying the different burners to figure out which one corresponds to which effectively means you have to learn the object to be able to use it, which really is not necessary. And while this is kind of a mundane, everyday example, it just goes to show the design of objects does impact how people interact with it, and it affects society as a whole. And it's definitely not a new concept, but it's, I think, one we appreciate a little more. Switching gears to talk about innovation real quick. So innovation, you could think of as a new method, a new idea, a completely redefining a currently existing process in order to be more efficient or better. And this is, again, another thing that's really come about with COVID. It's a silver lining of it. I mean, right now, hopefully this is not you guys watching this lecture, but whereas a few years ago I would have been speaking physically, now we're talking over Zoom. How we interact with our doctor has changed, and how we interact with even going to a restaurant or a bar has really changed. And it's changed that I think would have happened eventually, but was significantly accelerated. And we definitely felt that in the kind of innovation space. As you could see here, there's a steady growth of the amount of investment. And this data is a little old, I apologize. It's partway through 2022. I had taken this slide, but you could see from 2020 to 2021, there was a doubling of funding went into projects in this space to create new innovations. And this resulted in the growth of a lot of exciting new spaces within medicine. We have a lot of new devices under development. We have the use of AI. We have telehealth. And specific examples, so I'm an emergency medicine physician. Specific examples I could give you are, one of which that I think should come to market soon is this scope that allows you to rule out brain bleeds by just wanding over the head. And so where previously you would have had to do a CAT scan to see if there was a bleed or not, it was very binary. Now we have an additional tool that's faster, doesn't use radiation, it's probably cheaper. We could get more patients to the emergency room such that there's more space for the other people who need it. There's another cool thing that I've seen is there's these cartridges that will allow us to differentiate between bacterial and viral sepsis earlier, hopefully be able to get them the treatment they need at an earlier point, again, to improve outcomes. So I kind of wanted to talk about innovation real quick because I think this is kind of occupying everyone's headspace. And this is what we think of when we think about innovation. We think of a new device that rules out bleeds, and we think of a new device that detects infection in a way that's never been done before. And while this is important and needed and should be celebrated, I think the problem with having this perspective on innovation is that it creates this idea that you have to have a once-in-a-lifetime idea. You have to quit your day job or leave academia and put all your hours into it. You find investor funding and go all in, and you get the right timing, and you might become the next BrainScope. You might become the next Apple. And that's not the only space that exists within innovation. And I'm an example of that. And I would argue that most people don't have one great idea in a lifetime. They have multiple good ideas, probably every year, if not every month. And if those ideas were acted upon, I think would be to the benefit of us all. And this is something that I realized as a resident, and I kind of acted upon, to which the outcomes were just as positive, I would argue, as the new BrainScope. And I think it's something I wish we would see more of. And I'm hoping to be able to convey how to do that with the right kind of thinking in this lecture. And so it's innovation. And now I'm going to call what I'm defining as innovation, intuitive innovation. And that's the kind that's a lot more pragmatic and easy to approach for anyone to be able to make reality. And so switching gears now to talk more about the intuitive piece, What I mean by intuitive is, let's say you see an existing process that's very inefficient. It takes a long time to get from A to B. Well, along one line of thinking, if you want to try to innovate on this, you might redefine it where you don't need B, or you bring them closer, or you redefine the whole thing so that there is no A and B. Whereas intuitive, I want you to think as simple as possible. How can I connect A to B to make what would be intuitively the fastest way from A to B without using much brain power? And a very specific example of that is, and this is an object that was created as part of an art collection that is purposely meant to be ridiculous, but and you look at it and you wonder when you actually use it, what's going to happen? Well, you're gonna burn your hand. It doesn't make any sense. And so the intuitive thing, which immediately pops to mind, whether you're trying to think about improving society or just want to use a teapot, is why don't we just turn the spigot to face the other direction? And this kind of thinking actually goes a long way and can actually really get you started on the pathway of creating what probably can impact a lot of people's lives in a very positive way. And so I want you to keep this example in mind. What is the everyday problem that we run into, and what was the simple solution that popped in your brain? And now switch gears and think, well, what if I actually had a way to act on that and bring that to reality? Then I think that might be worth doing, is the kind of thought I want you to have. And so I've kind of talked about what I want to define as intuitive innovation. And so I'll kind of get into the specific examples of how I did this within the clinical context. And so I was an emergency medicine resident, and like any other good resident, I spent a lot of time and effort trying to keep up with the latest evidence-based guidelines, which at this point are coming out nearly daily. And medicine evolved from talking to some of my older attendings, where back in the day, the oncologist would have to know 3 drugs or 4 different drugs, and as long as you knew those like the back of your hand, you would know all of medicine, and it was very simple to keep track of everything possible that could happen. Well, nowadays, with the new guidelines, as I was saying, coming out nearly daily, it's really, really, really hard to translate all of that to our care at the bedside. And so thinking back to the intuitive kind of problem, me, and definitely not alone, had this thought, there's just too much information. It's very hard to keep up with. And even as an attending now, I can't say that I always bring the best evidence-based care to patients at the bedside. And this really came to a head in COVID. I was practicing in New York City, and what we were seeing is there's an increasing number of people practicing in care areas outside their specialty. And so now not only were they trying to keep up as much as they can with their own specialties information, you would have psychiatrists and radiologists redeployed to the floor taking care of patients with COVID when they haven't had touched a patient probably since medical school or used a stethoscope. And this really came to a head with young people now going into cardiac arrest. And now it really mattered whether they kept whether they were able to stay to this cardiac arrest algorithm or whether they deviated from it. And even slight deviations of which can have huge changes in outcomes. In this case, it would have meant the difference between life and death for pretty young people. But it is an algorithm that we all learn. And it is an algorithm, even if you are a radiologist, I think you would have to have done in med school and probably refresh once in a while, every tech, every nurse. Yet, because you don't regularly practice it, again, this becomes an evidence-based guideline that probably saves lives, but we're not able to make use of at the bedside. And so the light bulb moment was, hey, and this is because I went through a few frustrating experiences where I had an attending physician, or I saw physicians that didn't really remember how to do cardiac arrest. So the intuitive innovation here was, well, how can I get the reference in front of these clinicians at the time when they need it most? After all, this algorithm is everywhere. In fact, when you do the course as a medical student or you do the course as a resident, you're handed a placard, a physical copy of it to keep with you. Theoretically, you should be on shift, and when this happens, you should have it in your pocket and you pull it out. When you ask people, though, they don't. They usually immediately throw it away after class, and nobody brings those kind of physical references in anymore. And so the A to B innovation in this case, with that perspective, was, hey, why don't I create some kind of tool where they're able to have it in front of them during the cardiac arrest? And here's where I want to introduce what's called a product development process. So this is a development process that's been used in the business world for a few decades, but by following this, I was then able to create a solution for the problem I had identified. And for multiple reasons, this works really well in academia. What it is basically you build what's described as an MVP, or a minimum viable product, or something that you can build right away and start testing. You then give it to the end users to use it, and then you take any feedback they give and incorporate it, and now you have version 2.0, and you do this again, 3.0, 4.0. And so to give you an example of what an MVP is, let's say I'm trying to create a light that can be used during camping. Well, you don't start by going out and trying to describe the light and write a lot of papers about what you're theorizing about. You go and you get a set of matches, and then you give it to campers. Something you can do right away. Go to the store and build right away. They use it and they come back and tell you these matches don't work wet. I have to hold it in my hand. They run out. And then you incorporate, okay, these are the features that I need in order to create a light that works during camping. And then you integrate it, and then you do this over and over. And now you have data along the way that you're able to show people, which is great in academia because that could be used to justify more resources and recruit a team, as I'll talk about in a bit. You're following the scientific method where you're incorporating observations into your products, which is something that takes training to do, but I think is inherently advantageous within academia. And there's no waste in resource use. You're not building features that are not necessary. And in fact, you're building a hammer to hit the nail that you've already identified. So you're not creating a solution and then trying to find a problem. You have a very clear problem, and you're building the solution in a resource efficient manner together with the end user. So inherently, it's going to be very useful. And so how this worked out in this situation is, for example, what can I build right away to start the process of trying to solve the problem of getting this algorithm in front of people? Well, I could start handing out physical placards, but I already know the feedback of why those are not useful. I can get a JPEG file of this and then try to upload it on the hospital's network, so that, and then send out an internal email. Hey, you can easily access cardiac arrest on your phone if you go into the intranet. Well, we did something like that, and then we got feedback. It's too slow. I forgot about it. It was buried in a bunch of emails. And so I took that data that people found it very useful, but it was hard to get to for these reasons. I found someone who can create a very, very simple app where this is an unreleased app. It was much easier than you would think. We used a tool similar to WordPress, something that you're able to just move building blocks around without needing to necessarily know the backend coding. And we decided to put, based on that feedback, all of the different emergencies as JPEGs, where you would tap it, and then it would be brought to an algorithm that helps you address that specific emergency. We then brought it to the end users, i.e. these clinicians that are practicing in the context of COVID, and say, hey, try to use this. Mostly friends and people willing to listen to us, so a couple dozen people. We then go through this process a few times. We got feedback, hey, the other algorithms were not that useful. I really just need to know the cardiac arrest one. I also need to be able to do it with one hand. I need to be able to use the app without trying to figure out which one to go to. So it needs to be intuitive. And we also got a lot of requests. Hey, is there a way I could keep track of the different medications that we've given in cardiac arrest and the times during which that happened? We went through this product development process a few times, and we ended up with what ultimately was called CDH ACLS. It looks, as you can see here. And we did this with no resources, and we did it by following the product development process. And this got a lot of positive feedback. We started to get a lot of users that say it really impacted the care that they were able to give to their patients. And this found enough success where the AHA stepped in and actually co-branded it. Now it's distributed as part of all of their courses, which they give to pretty much every person practicing in a hospital on a regular basis. And what I want to try to emphasize here is that in academia, data goes a long way, and having a prototype you're able to show people goes a long way. And you need it in order to be able to, obviously the standard kind of pathway that different research projects are done or products are built is you get preliminary data, you find the grant that justifies it, and then you study it, and then that justifies further resources that goes into it. Well, the advantage of having started right away with the prototype that even while basic allows you to gather some data is then you're able to show people that. And so every time we approached different interested parties, different the institutions that be, we had something in hand, even if it was very basic. And then we had a lot of specific feedback saying, I want this, I want it developed along this pathway. And so we were able to recruit, you automatically get interested parties who have different skill sets interested and involved, and you end up creating a team that's able to build something that is very robust and useful and reliable. This slide is meant to show just how many people were contributing in the end, and there was no financial kind of exchanges here. Again, it was all people within the academic space who each brought their own skill sets. And another advantage of why this works so with the product development process, just to kind of go back to it, is now every time you go to the learn step, you have a table of people with different skill sets. The designer is going to make sure that it's aesthetically pleasing or usable. The person who's more financially minded is going to make sure it's sustainable. The clinician is going to make sure it's practical. And they're not going to let their aspect of what they're good at understanding kind of fall through. And so just by incorporating the data and having all of these people be involved in the learn and build steps, you're then able to get from a JPEG to something that really makes a positive impact with no resources. And I think is very recreatable and reproducible within the academic context. And I think it's a lot more pragmatic than the traditional kind of way we've tried to create such solutions. So I'm going to kind of switch gears and talk about another mobile app that I followed a somewhat analogous journey. But again, I used the product development process, and I was solving a problem that used existing information already out there. I just made it, I innovated on it such that it actually became useful. In this case, it was cardiac arrest as a reference tool. And so in terms of Ultrasoundbox, this was a tool that helps teach ultrasound. And I came upon the idea when this is yours truly as an ultrasound fellow a few years ago. When the reason I spent an entire year learning ultrasound is that it's a very resource intensive process to teach and learn ultrasound. You can only have up to 2 or 3 learners at a time. And there's not really a way to circumnavigate that. So you need the time of a fully trained faculty, and you need to go to the emergency room and scan patients, and you need to do this many times before you're able to use this skill. And that's unfortunate because it's a very useful skill that I think if more clinicians knew how to do and apply, we would be to the benefit of all of our patients. And so the intuitive innovation here, again, like that teapot, if we just turn the spigot around, well, what if there was a way that I could learn ultrasound on my own time such that we wouldn't be able to have to do it in such a resource intensive process? And so I set out trying to draw out what kind of resource that would look like. I envisioned that the user would have to be able to ultrasound some sort of model and then get clips back that they then have to interpret and get feedback on. And this is not the version 1.0, but how that basically played out is I took a JPEG and then I had it where if you click different areas of the JPEG, it would play ultrasound clips. And then I had an interpretation of what the correct interpretation of those GIF files are. And then I had people, and so this is a version, let's say 3.0, but I basically had a JPEG and people would click different areas of the torso and they would be played ultrasound clips and then they would have to interpret it. And so I brought that to every student and resident at my institution. So that was something I was able to build right away with little technical know-how. And then I got feedback and they told me, oh, they want it to be accessible easily online. They want it to be in the context of a clinical case. And so this kind of evolved. And I then went into another cycle of the product development process. I did surveys. I did an RCT actually, where I had half of the medical students use this tool and half of them not. And I found that in their existing ultrasound exam, those who used it actually performed better on this exam. And there was a lot of feedback that was very positive. There's also a lot of constructive feedback that was able to help us along on the process. But the takeaway from this is I was able to create this in a very resource low way. Once I was able to show that the JPEG that you could click different areas on was able to engender so much learning. I then was able to approach another person in academia and say, hey, if we code and build this thing out, I think this is going to really help people. This is not me theorizing that that's the case. This actually is the case. Let me show you. Let me show you the survey data. Let me show you the RCT data. And it's hard to imagine that there would be anyone in academia who would say no to that kind of proposal and approach. And so then again, I was able to build a team of people with different skill sets. And this is a lot closer to the current build of what exists in terms of Ultrasoundbox. And we then eventually created a mobile version, again, with no financial resource use, and in a very efficient way, because we got a lot of feedback saying, hey, we want a mobile version. And I was then able to approach the developer and say, hey, I have this cool tool, and they're all saying they really want a mobile version. If you create this, I think a lot of people are going to use it. I think it's going to benefit a lot of people. We then were able to find a developer to do that, and people from all over the world were then able to use the tool, with the areas that are darker indicating more users. But it ended up being thousands of users that now all can learn ultrasound, and hopefully to the benefit of their patients. I kind of wanted to end on a note of I think it's fair to say these are not such intuitive innovations. Maybe these are actually great ideas, once in a lifetime great ideas, and I'm not showing very fair examples of things that you run into on a daily basis. So I had the thought exercise last week in preparation for this lecture. I'm going to walk into a hospital room that I've seen thousands of times, but now with the perspective of maybe I can actually fix things that I find an issue with or a problem with by following this kind of line of thinking. And 20 seconds in, I settled on the bedside alarm. And I could tell you the bedside alarm is something that, unfortunately, every hospital across America spends a lot of resources on to ensure that each patient has, but it's nearly entirely useless. It doesn't alarm when it should. And when it is alarming, it's usually because the patient moved or is going to the bathroom, resulting in us basically completely ignoring it. And so this is another example of an everyday thing that if someone sat down and acknowledged doesn't work, and if we innovated on slightly using the kind of methodology I described this lecture, I'm sure would go on to impact patients in a very positive way, and guide our behavior in a very positive way to everyone's benefit. And I can already imagine, just kind of thinking about it, well, if we just applied some simple machine learning, for which nowadays are free and online, Google and Microsoft and AWS all offer very cheap or free services to create machine learning algorithms. If I put in a bunch of alarm data and be able to create an alarm system that is right even half of the time, that's already 50% more accurate than what exists right now. And so what I'm trying to convey is there is so many opportunity for pragmatic innovation that helps everyone. And it's very practical and not as hard to do as you would think. And it's important to understand that, because we often think of innovation as creating a startup company and getting lots of funding and completely changing a certain process. But I still think there's a lot of work to do on the ground. And I think it's something that academia could do a lot more of. And this is just kind of my journey on how I've kind of approached and done that. And so while this kind of innovation is very important and should be celebrated, it's not the only thing out there. And then last thing I want to leave you with is these are two books that heavily influenced my own journey. I don't have any connection. I don't know the authors, but they have a lot of good concepts in there that I touched upon in this lecture. And so here's my contact information. And yeah, thanks for everyone for their time.
Hi, everyone. Thank you, Leland, so much for presenting on that. Really incredible work. I apologize, I missed the first 2 minutes. I'm John Pitania. I'm the program director with the Center for Digital Health. Thank you for presenting with us today. I do want to open the floor to questions, and I do see one in the chat, and I have more here as well. But could you comment on how these apps will accommodate changes in guidelines?
So that's a really, really good question. Back to my talk about what I see in shortfalls in academia, having worked with industry and within academia and trying to bring these pragmatic solutions to life. I've seen before the development of, let's say, a mobile app to help with, let's say, addiction or patients going through withdrawal. A lot of amazing evidence is created, and then it takes years to integrate it into clinical workflows, and then the project dies because the paper is already out. The invested parties have now moved on. They got their promotions or went on to other institutions. Or even if there was an industry partner, it wasn't done in a sustainable way and such that they lost funding or it's not profitable, and so they lose interest. And now you have this clinical workflows that took years to build, and all of a sudden the app is not updated or it's not supported anymore. And what I find happens is medical directors who put a lot of effort to make these things happen. I know a specific example where this happened. The medical director walked away feeling like this was a very terrible experience, and they don't want to do this anymore. And so this is a huge shortfall with academic projects where they're not created to be sustainable. This app, the fact that it then co-branded with an industry partner, in this case the American Heart Association, the one of the negative changes, so to speak, they made is now they added a subscription fee. But what that allows for is a team that's able to update the app and make it continue to be relevant. For example, we had these COVID guidelines that very quickly went away and were no longer relevant. They were immediately able to incorporate all of the different updates to ACLS that happened. And that was only possible because now we worked together with an industry partner to make it sustainable. But it's true right now within academia, if you create a solution, it's often only lives as long as it benefits the creators, which is what the reason that we set out to create in the first place. I think that is a role for working with industry that I think needs to happen more often to create sustainable interventions. And I think one of the evolutions I actually see happening in clinical medicine, I'm sitting on the consensus board for my specialty in approaching this very topic, is we're trying to create a framework by which industry can work with academia or different, in my case, emergency departments, to create solutions that work and are also sustainable. There's not really a good framework for making it happen, but I think that's where a very positive synergy happens. And I think on the flip side, if industry doesn't work with academia and we don't have that synergy, what you run into is they start to create solutions that don't actually help people, but maybe are profitable or maybe are very shiny and look interesting. For example, Amazon is creating a lot of amazing innovations in telemedicine, but they're not necessarily paying attention to the equity. They're not creating any evidence that it actually works. And so the synergy goes both ways. The industry can help it make it sustainable, and then for our part, we can make sure it actually helps and benefits people in an equitable way. And so I think the solution and the answer to your question is a synergy of industry and academia is probably the best case scenario that I've seen personally. And that's actually how it played out for this specific app.
I appreciate you sharing that, and I want to highlight, I think, that I think there's a lot of opportunities for positive synergy between academia and industry, but I also want to, I think, call out and get your opinion on this of there's clearly a difference in pace and timing and urgency between the two parties involved, and it's reflective, right, of kind of the motivating factors behind each kind of perspective, where in industry, it is looking to say, what can we push out quickly to make it shiny and cool and pretty and quote unquote, marketable and sellable to the population, while academia is like, no, we need to do it. We need the RCT, we need the steps, we need to think about equity. Both are right, both have that strength, but they're inherently opposing each other. How do you reconcile industry that wants to go so quickly, academia that sometimes needs to go so slowly, and that, when you factor in time, money, resources, that whole kind of confluence of factors, how do you reconcile that to create and promote positive synergy?
I mean, this is a really important question, and always comes up with these kind of interventions. I think there's obviously always a balance with everything else, and in certain ways, I think right now we've gone actually too far in the direction of industry moving ahead without any empiric evidence. They have a lot of funding and are creating a lot of things that don't necessarily help patients in the end. And while their announcements are very loud, when they don't work or they lose their funding, it's very quiet, and we don't ever hear about that. Emergency medicine historically has been we can't work with industry. It's evil. It's not okay. And I think in some ways that has held us back. And I think now, to address your exact question, my entire specialty is getting together in our academic conference in 5 months, and we're having this exact conversation. How can we create a pipeline where industry should want to work with us, can approach us, and to be able to test their products, to work with us to make sure that it actually works as equitable in a way that they would encourages them to do so. And from our perspective, how do we start creating a framework with which to evaluate these tools and with which to start integrating them into clinical workflows? I think right now there is no framework and there is no system. So it ends up being, in my experience, an old boys network where they just call the doctor they know, and that one doctor gets some extra funding to study the thing, and then that's the end of that. But I think these conversations need to happen more for the benefit of everyone. But it is inherently conflicting, and I think that balance is lost, and that a lot of private industry is full steam ahead without paying attention to. I mean, telemedicine is a good example. Without paying attention to, does everyone benefit from this? Is it just young people who are really good with tech? Can older people who don't use tech that well or don't speak English use it? Or they don't have good internet, can they also use it? These are questions they're going to completely ignore. And so having these conversations will hopefully engender more of those questions being answered. And so I think to your point, we just need to have these conversations more. We're like we need to start step one, and I feel like we're not even there yet.
It's always that interesting. In our experience with the Center for Digital Health, we agree, right, that it's important to have those conversations to bridge the gap between industry and academia. And I think that a challenge we've kind of observed is who is going to be held accountable or responsible for making sure that those conversations happen, when inherently there are those kind of conflicting perspectives, conflicting timelines. How do we create a space that promotes synergy, that promotes collaboration, but at the same time provides accountability, so that one is not necessarily superseding the other? So how, I guess, this is again an open conversation that I would love to get your opinion, and maybe the folks here. How do we go about doing that? And how do there's no one governing body that says you should do this. It's self-initiated, right? And it's saying, but just like the work that you do, of like we should be doing this. Let's make it happen. We prove it in this one instance. But how do we make a paradigm shift in our fields so that this is the norm and not the like, oh, look at the cool thing that one person's doing?
Yeah. No, it's hard, and I can only comment on my specialty, where I'm seeing a lot of very positive movement in that direction. But it's definitely not easy, and I think as I was saying, we haven't achieved the first step yet. But us talking about it right now, and people kind of thinking about it, hopefully engenders more conversations. And when my specialty puts out a whole statement on it, this is why we should do it, this is how we should do it. Hopefully, because we're about to see an explosion in telemedicine. Patients in the emergency room are no longer going to be only in the ED. We're getting a lot of data on them before they hit the ED. We're getting a lot of information after they leave the ED. Harvard has this amazing hospital at home program where they're admitted, but then they go home, and then using a lot of pretty cool tech, they're able to still monitor the patient at home as if they're admitted. We're seeing an explosion in this, and more than ever, I think there needs to be more of our voice, and so I'm happy to see that happen. But if we don't start moving faster, I think we're going to miss the ball, and telemedicine is going to explode without our input, and that would not be ideal, because we don't even know if they help patients right now. There's not a lot of empiric evidence that it does.
Good point. Other questions from the audience here?
Can I just make a comment to that particular discussion? So I'm actually an intensivist. I work in the neurocritical care unit. So I've kind of been, I should say, I've been on the sideways kind of interested in this idea of like digital health and innovation. Just with regards to this concept of like, you know, as a physician, if you have maybe not very much experience with this, you have ideas that you see and you get all the time at bedside. It's really hard to put into practice when you don't have the connections to do so, especially if your ideas involve things like maybe programming, and then you also need an engineer to build whatever tools you have envisioned in mind. The one thing I did find helpful, so I was a trainee at Yale prior to coming here. I participated in this program called Bionucleate Health. I don't know if you guys have heard of it, but it's basically this group that has tried to bring together trainees from various different backgrounds, so medical trainees as well as people who are doing maybe a PhD or a postdoc in various science departments who have ideas, and also like a business aspect of it, so students in business admin, etc. And they put us in groups together. If we're interested, we get along together, and we're interested in working projects. So the medical trainees act as consultant to these science people who have ideas that they want to bring forth to the medical world. So I found that experience actually quite useful. They also, I think, gave us a bunch of lectures on how to bring products out to the world and all the steps you have to take. So just something to think about. I don't think Brown is involved in that project, but there's a bunch of other institutions that's part of it.
That's awesome, and you know, I do wish there was more of a curriculum of that. I was very lucky to run into a similar program, so to speak, and it made me realize, hey, I can also do these things. And I think that's not a realization that we teach a lot of our trainees. And more to your point, there's so many people with so many amazing skill sets in the environments we work in. And it's very easy to build a team of people to make these things a reality. We just, and so any program that kind of creates conversations around it or connects different people, I think would engender more pragmatic solution creation. And so it's cool to hear it exists at Yale. I think would be cool is if then they export that program elsewhere.
Yeah, they have a few participating programs, like some of the West schools, like UCLA was part of it, a bunch of the UC schools. Harvard was part of it, and then they have some other Southern schools. Unfortunately, I think Brown, I don't know, hasn't been invited, or we haven't volunteered to participate. I don't know what it is, but you know, I think the alternative too is that we can also, somebody can create our own Brown little think tank where we can bring everybody together and, you know, have different specialities work together.
Yeah, and I think Megan Rainey has somewhat engendered some of that, right? I mean, we're here talking now, but basically at the Center for Digital Health.
Yeah, I think that's the Center for Digital Health having been created in July of 2020, so about 2.5 years ago now. That is part of the hope, part of, you know, to kind of foster and create that community. I think what would be really helpful is having conversations like this so that we can pull in interest from clinicians and researchers and folks within the Brown and Lifespan communities. So I encourage you to email the Center for Digital Health email, and we'll put that into the chat if you want to be kind of a bit more involved or help us plan that out, because we're still in this growing phase to see where is the need, where is the want within our community here.
For sure, we'll do.
Yeah. So there's another question here in the chat, which I'll kind of read off here. So you mentioned that people have a lot of good ideas that are not acted upon. What do you think are some of the biggest barriers to these ideas not becoming reality?
So I think, and it's kind of what I tried to talk about in my lecture, is that people don't really have a framework for approaching how to get started in making that idea a reality. If you have this idea, the traditional idea of innovation, what we growing up seeing Apple being a success, for example, is that it's only for certain people who are able to obtain a lot of funding, who then go all into it. And so if you have a very practical way of making it a reality, as I was able to, and that's why I kind of try to talk about the product development process in the context of academia, then it's not as intimidating to get started. And so what I would advise is, if you have a certain idea, what's the most basic MVP you can start with? And anytime that you have a prototype in hand and data, you're always able to convince people to give you more resources, or have people join your project, especially in great academic institutions such as ours. You would not be there would not be a lack of people who would probably join you in your endeavor in making it a reality. I will say it does take a lot of time, but that's something we always can give more of. You can't always give more resources. And fortunately, what I was able to describe only takes a lot of your time, and it does take a lot of time. It's like anything else. It's a labor of love. But if where there's a will, I think there's a way to make it happen by following this kind of way I described. I'm not going to say that's the only way, but what I want to try to convey is that these ideas would be a benefit to everyone, and that it is possible.
Thank you for sharing that. It is definitely a labor of love, a kind of, we're, I think, creating the next the next movement, I think, within health, and trying to really it's innovative. It's something that I think that's really needed. So thank you for sharing that. Are there any other questions from the audience here?
I'll also want to say, I came up with the idea for this lecture, but if anyone there wants to innovate on their bedside alarms, that won't be too hard. You can get some data where you say, these are false positives, these are false negatives. You run it through some machine learning, and it's going to be better than what we have now. And that's already maybe like an amazing thing, right? I actually found it funny. Okay, with this mindset, I can step in the room and figure out what can be improved that we run into every day. And that's actually probably an amazing project. So anyone out there wants to try it, feel free.
Great.
Well, I personally can't tell you how much it's a problem for me, but how nihilistic I've become about it. It's just nice to hear that you're not nihilistic about it. You're still with wonderful, googly eyes that this can be solved. That's great.
It totally is. Now actually getting implemented, that's a different question. But if you can create a solution that shows it works, that's already a huge step, right?
Yeah, totally agree.
Well, there's no other questions. Leland, thank you so much for presenting at the center, at the seminar series. I truly enjoyed this, and I think we'll be following up, because I don't know if you've heard about our digital health innovation certificate based out of the School of Professional Studies. It covers similar themes here, so I'm wondering if there's opportunities for you to be a guest lecturer, kind of share your expertise in that space as well, to kind of share this knowledge with a larger audience. So thank you to you for presenting, and thank you for everyone for coming. We will be posting this recording on our website and our social media, and I hope you can join us for our next seminar series. Just look out for an email.
Yeah, so that's awesome. I think that'd probably be a lot of fun, and thanks for having me. It was really enjoyable.
Absolutely. All right. Well, thank you all. Hope it's a good rest of the day.
All right.
Thanks. Bye.